Okay, awesome. So welcome everybody to the fourth annual Virtual Diabetes Symposium. I am the Executive Director, Sarah Bloom, and our president is Kimmy Moore. We're so happy to have you guys here. We had a record number of registrations, over 200. And I see there's 94 participants, so this is great. The webinar is being recorded and slides will be shared on our website in the coming weeks. So if you don't attend in person, or if you can't make it tomorrow night, or you have to leave early tonight, you can watch the recording. Unfortunately, you do have to attend live and fill out your evaluation to get your CEU credits. So for Zoom will let me know how long you were in the webinar, and that's how I determine out of the 4 credits how many you get. So I just have a few slides. Okay, so who we are, the Diabetes Coalition was formed over 20 years ago as a statewide nonprofit that works closely with the state. And we have people, healthcare professionals, organizations all throughout the state, all the healthcare hospital systems are involved, and we meet quarterly to work to help people living in Delaware with diabetes. We do host 2 events a year, this being one of them, and the other one is our annual expo, which I'm happy to report is moving back to November this year for National Diabetes Month. So that is really a community event with vendors and education sessions. We'll be at Del Tech on November 12th. So, oops, sorry. Slides are moving along here faster than I want them to. Okay, so a reason that we actually started this particular event and to target school nurses is to let you know about our college scholarship. And every year we have a $1,000 scholarship to students living with type 1 or type 2. They can be a current senior in high school or a student in college. They just have to be a Delaware resident. The application is due April 30th, and it is an $1,000 award. And please let your students know, because every year if I get 1 applicant, I feel lucky. So we just are trying to spread the word on it and get more applications. I apologize. My daughter must be out of mac and cheese. So a new thing that we want to tell you about, we're very proud. We partnered with the local Lions Club from District 22, John Monahan. He's not on tonight, but him and Amy Hastings, who's a school nurse in the Apo School District, and as well as the DOE, we all partnered to apply for a grant through Lions International. And we found out about 2 weeks ago that we were awarded the grant to be able to purchase education online diabetes training for all school professionals, school nurses, coaches, bus drivers. And we did do a pilot program. And if you're not familiar with it, this Diabetes Coalition did purchase 25 licenses, 1 for each school. So if you are a lead nurse and you're not familiar with this, please reach out to me. I'd be happy to share some login information so you can get experience with the program before we launch this whole program in March or April of this year. And that can go school-wide. So we're very excited about this grant opportunity. Okay, so the important things about how to get your continuing ed, I mentioned you have to watch the webinar live. You have to complete your evaluation by March 1st. Tonight you'll get 2 hours, and tomorrow you'll get 2 hours. You can get them in any of these 4 categories. And the pharmacy education is new this year. We've never done that before, so we did add that actually just in the last week and a half. So that was exciting to expand that program. And any disclosures are posted on our website. The learning outcome for tonight, you will report on increased knowledge of available type 1 diabetes screening, ways school nurses can support families of children with type 1 diabetes, and how formalizing a transition process from pediatric to adult endocrinology clinics will aid in a student's success. Those last 2 are tomorrow evening. And I believe that might be my last slide. So with that, I will stop sharing my screen, and I will go on mute and shut my camera off. But Kimberly and Kimber are going to present for the next 2 hours on screening for type 1 diabetes. Their bios are very long and very thorough, but they are from the Barbara Davis Center and extremely knowledgeable and have been doing research in this topic for quite some time. And so I'm excited to share their presentation and have you guys here with us tonight. Thank you so much.
Thank you, Sarah. So I'm trying to share my screen and it's saying that you've disabled participation.
Of course it has.
And of course, I remembered I forgot to send you our slides. So if I need to email them to you, I can.
Oh, yes. Yeah, please do.
Okay.
All right. I changed it to multiple panelists can share simultaneously.
Okay,
Let you know.
See. Let me see. Hold on. I think it's working now.
Yeah, perfect.
Okay,
all right.
Great.
Thank you.
All right. Thank you. Yes. Thank you for having us here today, this evening, to speak with you guys. As Sarah said, Dr. Kimber Simmons and myself were from the Barbara Davis Center in Colorado. And we are here this evening just to talk with you about our programs that we are leading. The main one that we're going to be discussing is this program, Ask the Experts, which we developed a couple years ago. And it was in response to screening for early type 1 diabetes becoming more common and people receiving their antibody results when they were doing screening and they were positive and then they didn't really know what to do next. And oftentimes the families with these results and then also their healthcare providers were reaching out to us for guidance on what they should do next. And so we decided we should see if we could get some grant funding to start this program so we could be a resource to those families on what they should do next. And in the meantime, identify healthcare providers around the nation who we could train on early type 1 diabetes screening and monitoring so that they could help their patients locally as well. So that's why we started this program. And we'll just kind of go through these slides and talk to you about the program and what we can offer. So the learning objectives this evening with this presentation are that we want to discuss the natural history of type 1 diabetes that makes screening important. We're going to discuss the ways to identify people who have early type 1 diabetes, and then once they're positive, how they can be monitored to prevent DKA and to provide opportunities to delay onset. The learning objectives include describing why screening for type 1 diabetes is important, being able to recognize the stages of type 1 diabetes, becoming knowledgeable of the available options to screen for type 1 and to inform families of those options, and then to be familiar with early treatment options that are available through clinical and research pathways. Okay. So first we'll kind of just talk about the Ask the Experts program and just do an overview of that. And then we'll kind of walk through step-by-step screening, confirmation, and monitoring. And then we will leave time at the end for discussion. And then actually before we go to the discussion, I'm also going to show you guys our website and how it can be used. So disclaimers are that data is lacking in some areas and that guidance is really driven by expert experience and opinion. So recommendations are constantly evolving, and as they change, we will keep our website up to date so that people can see those changes as they're happening in real time. So the goals of Ask the Experts is to be a resource for healthcare providers and patients, and to build this national network of clinical and research partners so that we can provide education and support, monitoring and resources and guidance, and then access to early treatment interventions. And then, as I said, the big goal is to train healthcare providers throughout the United States so that they're comfortable identifying and managing youth with early type 1 diabetes. So at the end, I will walk through the steps of how you can sign up on our website to become a member. And that's really important because then you can have access to some limited, more exclusive materials that you can actually use with either your patients or even just to hand out to people that might be interested in screening. So we'll go through that at the end. So the current state of early type 1 diabetes includes this first step of screening and figuring out who should be screened. So this would be general population versus people who have a family history. And then for those people who actually participate in screening, and if they have a positive result, what the monitoring should look like. And then for those that we are monitoring and we've identified to be at risk for early T1D, then figuring out how we can let them know about the early treatment options to delay onset. So this infographic is on our website, and it's really helpful in understanding the different stages of type 1 diabetes. So some of you might know, but some might not know that there are 3 stages to the autoimmune process of type 1 diabetes. And of course, there is a genetic component to it. So there are genetics that put people at risk for developing type 1 diabetes. But about 9 out of 10 people, or 90% of people nowadays who get diagnosed with type 1 diabetes, actually have no family history of it. There is about a 10 to 15 times increased risk for those that do have a family history. So it's really important to understand that there is this silent phase of type 1 diabetes that can be detected by measuring these antibodies for type 1 diabetes. And the antibody testing is readily available and it's very reliable. So on this graph, you can see here that you have stage 1 of type 1 diabetes, and this really starts when somebody's been identified to have multiple antibodies for type 1. And at stage 1, their glucose levels or their glycemic status has been determined to be in a normal state. Stage 2 is when somebody has antibodies for type 1 diabetes, but now they're starting to show impairments with their blood sugar levels. And this is when clinical research trials and now the available treatment to delay onset, Tzield, these are the people that would be eligible for those clinical trials or the medication. And then over here you have stage 3, which is diagnosis. So they have antibodies, and then now they've been showing that their glucose levels aren't normal any longer and they can't keep them normal and they require insulin. So why would we want to screen? So it's really important to screen because we can provide anticipatory guidance. So risk for type 1 diabetes really depends. You can start with looking at the history in the family. So there's a 5 to 7% risk with people who have a first-degree family member, or 1 in 20 risk. There's a 1% risk for people who have a second-degree family member. And then if there's no family history of type 1 diabetes, it's about a 1 in 250 risk. And then overall, antibodies are detected in about 1 out of 100 kids. And then, as I said before, 90% of youth developing type 1 diabetes have no family history. So this really points to that importance of doing the general population screening, as well as screening people who have a family history. The benefits of screening are that you can reduce DKA at onset, which is going to improve outcomes at diagnosis and then also with long-term management of the disease. You can also provide time for education and health and behavioral adaptations. And then you can provide access to infusions such as Tzield or the clinical research trials to delay onset. So this is one of the more common questions that we get, right? Is if we're going to screen, when should we screen? Because we can't really be screening all the time. So there is new data and information that has come out in the past few years here that screening at age 2 years and 6 years has an 82% sensitivity and a 79% positive predictive value for type 1 diabetes by the age of 15 years. So when providers are asking us, okay, if we wanted to screen and we really wanted to limit it down to certain age groups, who could we target? And so that would be our recommendation, is the 2 years and the 6 years. However, we did put out a new publication from the Barbara Davis Center recommending that screening for antibodies at regular intervals that align with the standard well-child visits that occur at 1 to 3, 4 to 6, and 9 to 11 years also could improve feasibility with screening out in the general population and within primary care clinics. And we have already done this locally with a couple of practices that we've partnered with. They are actually incorporating obtaining the screening sample at the time of when they're doing like lead and anemia screenings. So the child's already having to provide a blood sample, and now they're just kind of piggybacking getting our sample at the same time. Granted, this is all through research, just to keep in mind, so they do have to have those people sign a consent form at this time for the people in the general population. So this table is from our website, and it just goes through the different options that are available right now to have somebody screened for the antibodies for type 1 diabetes. And you can see it's broken down by research-based screening programs, consumer laboratories, and then clinical laboratories. And then each of these is also going to be available based on where the person lives, how old they are, and then it also breaks down what they're going to be screened for depending on who they decide to do the screening through. And then it also goes through if there's an order required for the screening. So the ASK program is our program out of the Barbara Davis Center. So that stands for Autoimmunity for Screening for Kids program. And that one's general population screening. So anybody starting at the age of 1 can actually get screened for the 4 antibodies for type 1 diabetes and then the antibody for celiac disease. And then there's also the Cascade program in Washington State, Pledge in South Dakota. I'm sure many of you have heard about the TrialNet study. And then there is the Enable Biosciences Lab that is partnered with the JDRF program, the T1 Detect program. And then we have the clinical laboratories as well. So thinking about where you're going to get your screening done at is important depending on what results you're wanting to get. So if somebody gets screened with the TrialNet study, at that initial screening currently right now, that protocol is that the person's going to get screened for these 2 antibodies, for the GAD antibody and for the insulin antibody. And then if they're positive for either of those at confirmation, then they will get screened for all of these antibodies right here. Through the ASK program, they get screened for all 4 antibodies at the initial screening, and then also included is the celiac testing. And then the T1 Detect program, they're screening for just these 3 antibodies on the initial screening. And then the commercial laboratories, that's really going to depend on what the orders are. And then the clinical antibody testing is also available through the Barbara Davis Center. Now, it's important to note that, not only are the number and types of antibodies that are being tested through the labs, that can vary, but obviously the methods to measure the antibodies can vary. So sensitivity and specificity are going to vary. So it's just really important to think about where you want to have the testing done. And we would recommend that when you're thinking about getting screened, the screening test, if it comes back positive, it should definitely be confirmed with a serum sample, ideally at a CAP or CLIAFI certified lab that performs well in the ILA autoantibody standardization program. So this is another question that we get often is, okay, well, we've participated in screening and the result was negative. So does that mean that we're good and that we don't need to test again and that person's never going to get type 1 diabetes? And the answer to that is no, that we definitely would recommend repeat screening, as we kind of talked about a little bit beforehand. But it's also based on if there is a personal history of autoimmunity or family history of autoimmune disease. So we would really recommend that people with those types of situations that they're getting rescreened on an annual basis. However, if the rescreening isn't available annually, then we would lean on those brackets that we talked about before, where they should get screened between the ages of 1 to 3, 4 to 6, or 9 to 11. Of course, if symptoms or an elevated glucose or A1C occur, then we would say get screened sooner than that. And then if there's no family or personal history of autoimmunity, then we would just follow those age buckets that we're recommending. Okay, so this we already kind of went over. This was just really trying to point out that really with TrialNet, if you're positive for either of those 2 antibodies at the initial screening, that they are going to end up screening for all the antibodies at that confirmation sample. Okay, so what to do after a person confirms positive. So you've done the screening, they were positive, now you confirm them and they're still positive. So the first step is that you want to rule out a clinical diagnosis of type 1 diabetes, and you're going to do that by assessing for symptoms and getting an A1C and a blood glucose. And then you also want to counsel and assess the risk for developing type 1 diabetes in the future. So people who are multiple antibody positive, they are more likely to progress if they're younger. And the younger ones, we tell people where if they have a child that's 5 and younger, that their child's at risk for rapid progression. So things can just move a little more quickly for those younger kiddos. And then if they have more T1D associated antibodies, such as IA2A present, they're more likely to move on to a full diagnosis. And then those people who are single antibody positive are more likely to progress if their second antibody develops soon after that first positive antibody. And then also risk progression from time of seroconversion and high-risk individuals with antibodies. It's important to understand that that's been done in the past at gold standard laboratories. So that is the preference. And then for this person that's confirmed positive, you also want to discuss the treatment options that are available. And of course, monitoring is essential to prevent DKA at onset. So when discussing risk of developing type 1 diabetes, so when we're talking to somebody who has a multiple antibody positive status, the numbers that we give them for developing type 1 diabetes in the future is that they have a 70% risk of developing type 1 diabetes in the next 10 years, or about a 44%, 50% risk in the next 5 years. It's important to recognize that those numbers that we're giving about risk progression are really based on these birth cohort studies that have been done in the past, where we actually got to see these children from the point of them being not having any antibodies and then seroconverting to being antibody positive. And so when we're giving this information to somebody who has already had the autoimmune process going on and we're kind of jumping into the middle of it and we actually don't know when they seroconverted, that timeline of when they're going to develop type 1 could be different. So it's just important to recognize that when giving those risk estimates. Okay, so if you have somebody that's confirmed positive and then you assess their glycemic status, and let's say that they fall in this bucket where they have a random blood sugar that's above 200 and then they have an A1C that's 6.5 or above, you want to evaluate them for symptoms of hyperglycemia and diabetic ketoacidosis, and then obviously get them referred quickly to a pediatric endocrinologist. Now, if you have somebody that's confirmed positive and then you check their glycemic status and they're in this normal glycemic range, so they have random blood sugars below 140 and they have a normal A1C below 5.7, the next step is that you want to educate them on the symptoms of hyperglycemia and DKA. You want to definitely make sure that you have your staging right by doing the fasting glucose, an A1C, possibly an OGTT, and then maybe even having them wear a CGM if that's available. And then home glucose testing teaching is really important. That's one of the most valuable tools that we've realized we can give to families within our research programs. So we give them a glucometer, and then we recommend that they test blood sugars once a week, 2 hours after dinner, or if they're sick, or if they feel like type 1 diabetes symptoms are starting to appear, then they should definitely be testing. Follow-up and monitoring of these people, we recommend that anyone who's 5 years old and younger, that they're seen every 3 months to assess their staging and making sure that you're catching when transitions are happening. For people that are between the ages of 5 to 18, see them every 6 months. And then those that are 18 and above, they can be seen once a year. And this is all to ensure medical safety and metabolic staging. And to make sure you catch that time frame too, where you can talk with them about the options to delay onset if they're interested in that. So if somebody confirms positive and then you assess their glycemic status and they fall in this bucket where they're dysglycemic, so their blood sugars are between 140 to 199, and then they have an A1C between 5.7 and 6.4, you're going to want to do the same things that you did with the other group, where you're going to educate them on the symptoms of hyperglycemia and DKA, make sure you stage them appropriately, give them the home glucose teaching. And then these people, regardless of their age, you're now going to want to follow them every 3 months to ensure medical safety. So this is an example of one of the cards that we give to our research participants. And this is the guidance on how to do the home glucose testing and then what they should do based on the result that they get when they're testing blood sugars at home. So you can see here that the preferred method is that they test 2 hours after meals, and the normal range would be if they're below 140. If they get into this elevated range of 140 to 199, we typically then will give guidance to our participants to let us know if they're starting to see numbers in that range. And then definitely if they're 200 or higher, we definitely, tell them repeat the test and then contact their provider, or in our case, they can contact us and we can talk about next steps. And then this is on the back of the card. This is just giving a reminder that a high glucose level at home is not sufficient to diagnose diabetes and that it does need to be confirmed by a healthcare provider. And then it also gives the guidance of if you get an elevated result, please wash hands and retest to confirm that the result is still high. And then here's all the symptoms of type 1 diabetes. And then it differentiates between symptoms that require urgent attention versus those that don't. So this is just an algorithm that's provided on our website that gives essentially same information that we kind of just went through there. And we'll go through that in just a moment once we get to the website, and I'll go through and show you how this can be used for providers when they're working with their patients. So blood glucose testing responsibilities of the healthcare provider when the person has this range of 140 to 199. So now they're in this dysglycemic range. So you want to assess for symptoms of hyperglycemia. We then recommend that the person test blood sugars for the next 5 days. And we recommend that they do fasting blood sugars as well as the 2-hour after dinner testing, and then report those back. And then of course, the person in this situation, if they contact you and they say, hey, I'm starting to see these patterns, these blood sugars are increasing, you definitely then want to schedule an appointment so that you can get a blood sugar through the lab as well as an A1C, and then probably consider an oral glucose tolerance test at that time. And if available, also discuss putting a CGM on as well. And then you also want to have that conversation with the family that this could indicate that they are transitioning into stage 2 of type 1 diabetes. And then also take this opportunity to discuss with them the clinical trials and available medications to delay onset. So if you have a patient that contacts you and now they're seeing blood sugars above 200, same things you want to assess for the symptoms of hyperglycemia. And then you also definitely want to ask if they've been having any illnesses or new medications that they're taking to see if those could be affecting blood sugars. They can also check their urine for ketones. So we'll also do that where we give them ketone strips and they can use those at home as well. And then ketosis or intercurrent illness does necessitate evaluation for volume status and metabolic status. And then symptoms would require referral to a pediatric endo if they're not already under the care of a pediatric endo. If they're not having any symptoms, and if you determine that they have been sick recently, then we would say you could schedule an appointment for the next day so that then you could get your glucose, your A1C, your lab values, go over those symptoms of hyperglycemia. And then we'll recommend, okay, now after, keep during this illness, measuring those blood sugars at home. And then again, after it kind of resolves, keep going for the next 5 days and let's make sure that they resolved. And maybe it was just an effect of this illness that the person had. Okay, so an oral glucose tolerance test, or an OGTT, many of you are probably familiar with this. With our research participants, we actually do a 6-point OGTT. So they come in fasting and then we measure their glucose level. We do a -10 and then we wait the 10 minutes and then our 0 starts. So we'd have -10, 0, 30, 60, 90, 120. OGTTs obviously are very important to determine metabolic risk scores, which can help estimate the risk of prediction to a diagnosis of type 1 diabetes. Time points that we would recommend if you're doing one clinically for somebody who you're trying to classify staging of early T1D, we would recommend to do the 60, 90, and 120. And then be sure to get your glucose levels at each of those time points, as well as the C-peptides. And then this can obviously identify people that might be eligible for those early treatments. So CGMs are continuous glucose monitors. We have had a lot of success with these with our research participants. I will say oftentimes our participants aren't very excited about doing the OGTTs, but they are more inclined to wear a CGM. And that can be beneficial because if we can get them to wear a CGM, then sometimes those CGMs can start to show impairments that then kind of helps and encourages them to think about doing the OGTT, especially because the OGTT is important since it's part of the ADA criteria for the staging and diagnosing. And you'll probably hear later from Dr. Simmons, the OGTT is really important when thinking about the eligibility for T's yield. So the pros of the CGM is that you are collecting the blood glucose data while the person's in their normal daily activities. They don't have to do finger pokes while they're wearing the CGM. It reads a blood sugar every 5 minutes. And sometimes the CGM can actually detect impairments with blood sugars even sooner than like an A1C can, or even OGTT, and then home glucose levels as well. So cons of the CGM, you definitely want to think about if you're going to put a continuous glucose monitor on somebody who is in the early stages of type 1 diabetes and they haven't reached a point of diagnosis. With our research participants, we have them wear the CGM blinded so that they're not seeing the numbers. We tried doing them unblinded at first, and it was causing, a lot of psychological distress. And so then we moved to the blinded CGMs. So if you are going to put an unblinded CGM on somebody who isn't diagnosed, you would just want to be sure that you're counseling them and being able to have support if they're experiencing any anxiety. And we have some resources on our website too that people can use. So this is from a paper that one of our study doctors, Dr. Andrea Steck, published based off of the data from our general population screening from the ASK program. And what this is showing is that the risk of progression to type 1 diabetes in 1 year was 80% in those people with time above 140, more than 10% or more of the time. So this is really just speaking to the value with using the CGMs in people who are at those early stages of type 1 diabetes. So final conclusions are that the risk for detection of an early stage of type 1 diabetes through screening is highest in people who have a family history, but it's also significant in the general population. A positive type 1 diabetes antibody result does require confirmation. And then a diagnosis of type 1 diabetes should always be ruled out when you're seeing somebody who has a positive antibody result using a random glucose and an A1C. Regular follow-up of a person who screens and confirms positive for an antibody is really critical. This is something that I think is really important to note. Now that Tzield has been approved, there's been a lot of interest in screening now, and healthcare providers are more inclined to participate in screening, recommend screening, and that's great and wonderful. It's just important to recognize that, if we're going to increase screening and do more screening, we're going to catch more people that are positive, and they might not necessarily be eligible for Tzield, or some of them might refuse it. And it's important to recognize that those people are going to require monitoring. So just to really think through that. And then staging of early type 1 diabetes and discussion of risk is important, even though data is limited. And then ask the experts, we can help with confirmation and monitoring of screening detected individuals as needed. So that's the end of this slide. I think at this point, if it's okay, I'm going to actually move on to show you our website so that you all can see
And there's a couple of questions. I don't know if you want to address
okay.
those
Yeah,
first.
let's address those. Sure. Yeah. So do I just go to the Q&A, like I say?
I can just ask you. So the first one says that population screening has been conducted in other countries, and what have they learned from this mass screening?
You want to answer that, Kimber?
Yeah, I'm happy to do that.
Okay.
Hold on. Let me turn on my video. All right. So the country that's really done the largest screening is Bavaria, Germany. And they have been able to do that at a large scale and successfully because they are able, with their healthcare system, to get all of their pediatricians on board. So they've screened, I think, over 90,000 kids. We in Colorado have the next biggest general population screening, which is over 33,000 kids. And then beyond that, there are a lot of programs that are starting up. So Australia is one that is starting up. There's a couple more in Europe. So there are definitely a lot of screening programs starting, but they're all at a little bit smaller scale. And I'll have a slide on that in my talk. I think what we can say we've learned so far from the one in Bavaria, which is the biggest one, is really confirmation of a lot of the things we already knew, that by screening, you can prevent kids from being really sick when they're diagnosed with DKA. If you screen kids, the rate of having 2 or more markers, meaning that you have a lifetime risk of nearly 100%, is 0.31%. So low, but what we would expect. And then it having any risk for diabetes is higher than that, but having that really high risk of 2 or more antibodies is about 0.3%. I think that those are pretty much the main things that they've learned. The other thing I think that's been interesting is Bavaria has come up with a risk prediction score using the data from who they've screened and who's went to type 1 diabetes. And it uses a lot of factors that we already look at, like what is the hemoglobin A1C, what was the IA2 level, because we know that certain antibody has some increased risk for progression. So I think what's good is that there hasn't been a lot really that's been different, I would say, even doing general population screening from all of the birth cohort studies suggesting that there really isn't a difference once you have antibodies of your risk, whether you have a family history or high genetic risk, or you're just screened in the general population and positive.
That's a very thorough question. You should probably just keep going because you're going to be the one with like the most thorough answers probably.
Okay.
Yeah.
Do the numbers for people with family history versus no family history include adult onset type 1? So yes, they do. So for first degree relatives, whether that's a mom, dad, brother, or sister, the risk is thought to be about 5 to 7%. You know, adults who are diagnosed with type 1, we know that over half of new diagnoses are in adults, and that's because there's a much longer time from, you know, in the whole range of adulthood than there is in childhood. So the incidence, meaning how many new cases there are per year, is still higher in children, but overall more adults are diagnosed each year just because of the age range that there is in adults. So adult progression typically, not always, is much slower, and so can be misdiagnosed for a while and is probably actually unrecognized. So it may be that it's more than 5 to 7%, but that's kind of what we think is the case no matter who you are as the first degree relative. I think one other thing to point out there is that we have looked at autoantibodies in general population adults versus kids in the ASK study here in Colorado. And we saw that it was very similar, the amount of autoantibodies that were present in general population screening between children and between the 1,000 adults that we measured. So that also indicates that adults have the same rate of underlying autoimmunity that kids do. And then a little bit more about the C-peptides with the OGTTs and what have we learned about C-peptide. You know, the real reason that we recommend C-peptide is because in these studies over time that have tried to look at how you're going to predict who's going to need insulin most quickly, the scores that have been developed include the C-peptide values because C-peptide is an important predictor of that. So we know that as you get closer to diagnosis, your C-peptide goes down. And then I'll show in a slide later in my talk that we know that even preserving a very small amount of C-peptide over time is really important for your long-term outcomes and your chances for having long-term complications or severe low blood sugars.
You want me to read the next one too? Have you noticed how body habitus physical activity patterns impact the detection and glycemic excursions?
Yeah, I think the thing that we see most often in the, and Kim, you know, I'd be interested to hear what you have to say here. What we're noticing most often, I think, is actually related to diet. So once people know that they have antibodies, there are a lot of people that restrict their carbohydrate intake. And in adults, especially, that can actually mask diabetes for quite a long time. It doesn't mask it quite as long in kids. If you are to do an oral glucose tolerance test in these people, though, that eat a low carbohydrate diet, they will have floridly high blood sugars. So again, you can't really get away with that for very long the younger you are, but as an adult, sometimes you can do that for a while to kind of mask the high blood sugars. And I think that in another study called TEDDY, which followed kids from birth that were high genetic risk or people who had family members, it was seen that for kids who have moderate to vigorous physical activity each day, that their risk of progressing was a little bit slower than people who were not physically active. So that's just a correlation. We don't know if that's really, you know, what caused the slowing of progression, but it was a factor that at least was significant when looked at to see if it contributed to how fast people progress to type 2 needing insulin. And then
I would agree with that. I would just say that's, you know, back to the importance of just thinking about when you're putting a CGM on somebody who doesn't have type 1 and thinking about that, you know, when they're seeing those numbers and stuff, and yeah, they are going to start to correlate with like what they're eating and physical activity. And we have seen that where they do start to change those patterns. So yeah.
Yeah.
Definitely.
And I think it's really hard because, you know, I think is probably in your schools, you know, I think one of the hard parts is what do you do with food? Because you see that kids that eat really high carbohydrate diets, it can be harder to control their blood sugars. And I think, you know, sometimes inappropriately, the message is to eat what you want and just cover with insulin. And I think that really, you know, what we tell our patients is that we want you to eat a diet like we recommend for every other kid who is a kid in the United States. And how many kids eat a healthy diet that we recommend? And that's probably close to 0%. But when you have type 1 diabetes, or you have an early stage of type 1 diabetes, especially when you actually have insulin requiring diabetes, you have immediate feedback. So kids have feedback that their peers don't have, right? But it doesn't mean that their peers should also be eating a bunch of highly processed, highly glycemic foods. So we don't like them to limit carbohydrates, because carbohydrates are really important for growth and development. And unless you're completely fat adapted and eating no carbohydrates, your body is confused about which fuel to use all the time. And so that might be different for an adult. An adult, you know, may be able to make different dietary decisions, but for kids, we recommend carbs in healthy amounts that are, you know, lower glycemic index carbs.
So the last one is, what would a misdiagnosis be?
I think so. Misdiagnosis can be usually type 2 diabetes or pre type 2 diabetes. So we'll see people come in who have hemoglobin A1Cs that are slightly elevated as adults, like 5.8, 5.9. And they have been on metformin, which is a medication used for type 2 diabetes. And you look at them and they're extremely thin, active individuals who have no family history of type 2 diabetes. And so, you know, even though, again, because type 1 in adults can be so slowly progressive, sometimes it's just picked up as an abnormal glucose. And the automatic thing people think about, most healthcare providers think about, is pre-type 2, because that is what is really prevalent, as adults in our society have a lot of insulin resistance due to lack of exercise and poor diet choices, and genetics, because there's a big genetic component to that as well. So that's how it's misdiagnosed, is it's often diagnosed as pre-type 2 diabetes.
Yeah, so we will get, you know, that wasn't necessarily the intent of the Ask the Experts program, but it's been kind of a consequence of it being out in the world, is that people will find us and then they reach out asking for guidance on how they can really figure out which kind of diabetes they have.
Yeah, because they'll take metformin and then all of a sudden it's not working as well, for example. And so when they contact us, then Kim will usually work with them to get their antibodies checked and see if they have antibodies that are positive, so that they understand kind of what treatment would be best for them.
All right. I think that's all that we have in the Q&A. Okay. So I will move on to the website. Okay. So this is our website. It's www.asktheexperts.org. And so this is where a lot of people are coming now just to find out about our program. And, you know, healthcare providers come here, families are coming to the site. And it's nice on this homepage. You can see, if you scroll down a bit, we have these different tabs. So one for providers, for families. We also, while the Ask the Experts program, we've really been focusing on type 1 diabetes with this presentation, we also can provide information to people who might be trying to figure out celiac disease and if they're at risk for celiac disease. So we have that information available as well. At the bottom of the page, we have this map that we are continuing to add different partners to, and we're continuing to develop this map where we end up training a healthcare provider in a certain area. And then we just want to keep, as I said at the beginning of the presentation, expanding this network of resources. So that is handy as well. And like I said, we're continuing to work on it so that we can provide like contact information for those different people that have partnered with us. So if you go to team, it'll, just give you an overview of everyone that's involved with the program. And then here you can also reach those tabs. You have the type 1 diabetes information for providers, families, then information about celiac disease. I would recommend that anyone who is attending this session, and feel free to spread the word, you can come to this page, this T1D info for providers. And if you scroll down to the bottom of this page, there's a form that you can fill out, and then this information will come to me. And now that you've taken this training session or information session, once you complete this form, I can then actually give you instructions so that you can become a member on the site. Once you're a member on the site, you can see that I'm logged in here. So you only have access to this provider resources tab and this file share tab if you're actually a member. If you're not a member, you won't have access to these resources. So if you go to this provider resources tab, it's going to have a lot of different materials that you can print out or use electronically within, your office for your people that you're meeting with, patients or families. For example, this one we developed, and this just really goes through the differences of type 1 and type 2 because there is still a lot of confusion in the general population about the difference. It's really important to keep expanding that knowledge. This one's very nice because it has a good illustration of the 3 different stages of type 1 diabetes, which can be really helpful when explaining to somebody what stage they might be in. And then this is where I had said in the PowerPoint slides, we had resources for if somebody's wearing a CGM. So we have it for somebody who's in stage 1 and then stage 2. And then it just gives them guidance on what they should do if they are wearing an unblinded CGM and they're seeing numbers. And if they're getting concerned about either seeing elevated numbers, and then we often get a lot of concerns about low blood sugars too. So this is helpful in giving guidance. And then this is that card that we went over during the presentation. So that can be printed off or used electronically as well. So lots of resources there. And then this is really nice. This is an interactive flow chart. So a provider can come on here and they can just start plugging in the situation that they're dealing with. So they can say, okay, my patient did screening and they're positive for an antibody. So you click on that and then it's going to ask you, okay, if they're positive for one antibody, you definitely want to confirm the antibody and then get a glucose and an A1C. And then now if you've confirmed, where they confirm for 1 antibody or 2 antibodies, and then you can click on the situation that you have and it'll take you through what you should do next. So you can see here kind of what we discussed before. If somebody's confirmed to have 2 or more antibodies, you want to get the glucose and the A1C. And then here's kind of that follow-up protocol that we were talking about, the algorithm that we discussed earlier. So depending on age and glycemic status, what the provider should do next for the monitoring. So we would recommend that everybody go to the website, sign up as a member so we can get you approved. There's lots of different resources here. We even have instructions on how to do the glucose tolerance test, more information on home glucose testing, and then the information on the celiac disease as well. And yeah, so that is all that I had for my presentation. Did anyone, that looks like there might be another, just great resources. Okay, great. So yeah, I think that's all that we had. I don't see any other questions. So I can pass it off to Dr. Simmons now.
Sounds good. Yeah, I think a couple things just thinking about at least in a school setting. I think that there will be more and more antibody positive kids in schools, and we don't have school plans for kids who are antibody positive, so I think that some of the things that you'll in a school setting that you need to pay attention for, you will probably be the one of the first people that might notice symptoms. And so keeping an extra eye on kids that have antibodies with regard to, urination and thirst, or even just kind of thinning out, looking like maybe they're having a growth spurt, but maybe they're actually not gaining good weight. And then I think the other thing is that some kids that are in stage 2 of type 1 diabetes actually have symptomatic low blood sugars. So they don't have to be treated from a safety perspective. Nobody if you're not taking insulin from the outside, you're not going to have a severe low blood sugar. But if a kid is actually symptomatic and not feeling well, then having 5 to 10 grams of carbs to feel better is something that we would also support. And that really makes a difference for some people.
I'm glad you said that because, yeah, we've had a number of families that reached out to us about doing screening because the teacher actually recognized symptoms of type 1 diabetes. So it is a good point that you guys are a lot of times kind of that first line that is going to see those changes in a child. So yeah, and obviously the families are, very thankful that the teacher even pointed these things out. And we've even had teachers telling the families, I think something might be going on. It seems like it could be diabetes. I would really recommend that your child gets checked out. So yeah, it's a great point.
And then, Kim, there's another question that says, how are parents and caregivers generally processing this information?
Yeah, so it really kind of depends. I think sometimes people think that if there's a family history that they might process it really well because they're used to it and they're aware of it and they know about it. But then other times it's like, no, maybe they're not going to process it great because they do already know about type 1 diabetes. So, it really just kind of depends family to family. But it is a very important point that it's important to address the psychological impact that this can have on families, knowing these results and being sure that people have the resources available to get that psychological support because it can be really difficult to process. And especially because, we're just jumping into the middle of things. So sometimes when we do screening, we're jumping into the middle of this autoimmune process and things might already be in stage 2 and getting close to a diagnosis. So you kind of have to have those difficult conversations sometimes early on. So it's really important just to think about how you discuss the staging and the monitoring and what needs to be done next for the safety of the child.
Mm-hmm. Yeah, and I think we're still learning a lot about, I think the message should not be that screening ever is what causes anxiety. It's that we know that a certain proportion of people that get positive results are going to feel more anxious because of that. And so we're learning, and we have a psychologist on our team who's trying to get a grant to develop strategies for how to help people that get this news and deal with any anxiety or other feelings they have around that. Actual behavioral interventions. And the other thing I think that's interesting is risk perception, because there's a really big difference when somebody actually believes that they're going to develop type 1 diabetes, and then when people don't believe that they're going to develop type 1 diabetes and what that actually looks like. So we're still learning how to kind of, in all areas of this, how to differentiate the people that need the most support from the people that are really doing just fine. Okay. Okay, so now that we've talked about screening, I am going to spend some time talking about what do we do if somebody is positive and beyond just following them and making sure that they do not develop DKA. And so in this talk, I'll talk about the potential therapies that can modify the path of type 1 diabetes, provide an overview of some of the clinical studies, and then also discuss implementation of the first FDA-approved disease-modifying therapy, because hopefully we'll be seeing kids that have received this therapy in the future. So this is just the chart figure that you've already seen in the previous talk, but I just want to use this as background to remind us that type 1 diabetes is increasing, which we didn't really talk about, but it's increasing throughout the world at a rate about 3 to 5% every 10 years. We know that it's predictable now because we can measure islet autoantibodies before it is detectable. And so we have this asymptomatic time when we can detect it. And we know that there are benefits to detecting diabetes before somebody requires insulin. So the question is, what do we do? How do we intervene? And at what times do we do that? And so there's been a lot of studies saying, what is the ideal time to intervene? Is it when somebody just has genes that put them at risk, or when they develop their first islet autoantibody, or when they have 2 or more? And with all the studies that have been done thus far and looking at the different data, it seems like once patients start to have multiple islet autoantibodies or impaired glucose tolerance, meaning abnormal glucose is in response to a meal or in response to that sugary drink during an oral glucose tolerance test, that those are times that they probably will respond the best. If we look at clinical studies, most of the time we are actually starting studies in stage 3 of type 1 diabetes. And that's because for a very long time, and really it makes sense that to get a study approved, you want to do no harm. You want to have benefit and harm needs to be equal. And so it's easier to justify doing a treatment with an immune modulating drug, for example, in stage 3 of type 1 diabetes because kids are already on insulin, where it's been a little bit harder over time to do that in a population where kids are otherwise completely healthy. I think that is shifting because now we do know that if you have 2 or more islet autoantibodies, that you will eventually require insulin, and that there is some data showing that intervening earlier provides long-term metabolic benefits. So this is just to kind of show that we would like to intervene earlier, but we've done a lot of work once kids have already had insulin needs. And this is another way of kind of looking at this. So this is showing if you do nothing, once somebody has islet autoantibodies and you watch them, that they're going to slowly lose their C-peptide, which is what's over here on the y-axis. And it's going to go down, and it's going to go from having no real high blood sugars that are going to cause any, long-term problems, to then in the blue, where you're going to have a low risk of abnormal blood sugars, but they're going to start to happen. In the orange, if you don't do anything, you're starting to have blood sugars that will cause long-term damage to organs. And in the dark orange, then you are doing acute damage to your organs, not just long-term damage. And the other thing associated, as your risk for complications increases, your risk for low blood sugars also increases. So you have kind of both things that can be better if you treat earlier. So if you treat with an immunotherapy agent at stage 2 and at stage 3, that is as good as preserving blood glucose control for more than 5 years. And we know by preserving good blood glucose control earlier on that your body has metabolic memory, and therefore your long-term hemoglobin A1C is lower, your risk for complications is lower, your risk for severe low blood sugars is lower. So ideally, we want to treat in stage 2 before stage 3, and then in stage 2 and 3 if possible. But we have to find the right agents to do that. And so how do clinical trials work? How do we try to find these agents to use? And this is how studies are broken down. So there's phase 1, 2, 3, and 4 studies. Phase 3 studies are the studies that are big enough that those are what usually lead to the FDA approving a therapy for treatment. Phase 4 studies are post-market studies to see what happens in the real world. And then phase 2 studies are looking at effectiveness, but with and side effects with a smaller group. Most of the studies in type 1 diabetes are phase 1 and phase 2 studies because type 1 diabetes is not that common. And so it's hard to enroll hundreds of people into clinical trials. That's something that's easier to do in, say, type 2 diabetes, but not as much in type 1. So most studies have been phase 2. Okay, so when we're looking back here again and we're seeing the different places we can intervene, we know that this decrease in beta cells is because of autoimmunity or because of the immune system. So how can we actually target the autoimmune process to try to stop this process from continuing? And this is a very complicated figure, but I'm going to take a little bit of time to go through it. So the cells in the immune system, how I like to think of it is that your T cells are like little soldier cells. So when you look at this naive T cell here in the middle, that is your immune cell that is ready to get the message from its boss cell and go fight whatever it's told to fight. And so what happens is that the T cell gets messages, that's what this little T cell receptor is, from B cells or other immune cells that present pieces of protein of viruses, bacteria, things that you want your body to fight off. Unfortunately, your B cells or your other immune cells can also present pieces of the beta cell that makes insulin, or insulin itself, so that those naive soldier cells say, okay, great, I'll go get rid of the cells and make a mistake. So the question is, how can we stop that from happening? And, you know, some of the thoughts are, okay, well, we actually need to find ways to inhibit that T cell from being activated. So in order for that T cell to be activated for that soldier to go fight, it has to have a couple other cells stimulate it. It has to have, there's a couple markers on the T cell that have to meet up with another cell, and it has to be stimulated. So there's thoughts, can we block that stimulation? Can we actually block the ability for it to get the message? Can we give a medication that completely gets rid of it, for example? So there's a focus on inhibition of this T cell activation. There's also been a focus on, can we get rid of B cells that deliver the message to the T cells? And so that's another way we can look at trying to dampen the immune response. You have T regulatory cells, which are cells that actually try to re-educate the immune system to do the right thing. And so can we promote T regulator cells and get rid of the T effector cells that the naive T cells turn into when they go fight? And then the other thing is, once they start fighting, there's a whole lot of inflammation in the body. So are there things we can do to actually protect the beta cell that makes insulin itself and decrease inflammation, so decrease the cytokines or the inflammatory response around it, or actually improve the beta cell function? So it's kind of a complicated graph, but you can see how there's a lot of different places within the immune system that you could potentially intervene in the disease and modify the course of how it's going to continue. And so how do we know if these medications work once we pick them? And so unlike in early stages of type 1, like Kim just talked about, where we do oral glucose tolerance tests because that's a test to look at diagnosis and progression. Once a person has insulin requiring diabetes, we do a mixed meal tolerance test where patients drink Boost, which is like a liquid milkshake. It has all of the different food nutrients, not just sugar. And then at different time points, we measure C-peptide values either over 2 or 4 hours so that we can create these curves that show us how much insulin a person can make on their own. So C-peptide is the little piece of an insulin that breaks off when your own body makes it. If you give insulin from the outside, it doesn't have C-peptide. So if we look at C-peptide, we know that that's only insulin coming from your own body. And you can see that, you know, somebody can have a really low C-peptide at the beginning, but in response to a mixed meal can actually make quite a bit, where there's other people who would make more right at the beginning and have less over time. So that's why it's important to get all these different time points. So whenever we test these drugs, this is what we look at to see how well they work and to see if we always say keep insulin producing cells around for longer, but really it means making sure that they function and make insulin for longer. So there have been, I think what's promising is there's actually been a number of different drugs that have worked to preserve beta cell function or to keep the body making its own insulin for longer. And there's been 4 different drugs that block T cell activation. Abatacept blocks it by getting rid of one of those co-stimulators for that soldier cell. ATG actually gets rid of all of the T cells or the soldier cells. Alifacept also gets rid of the co-stimulation. And then teplizumab we'll talk about more in detail, but it's actually the only study on here that was a phase 3 or a phase 3 study compared to a phase 2. So a bigger population, and the results were just released last October. Rituximab gets rid of B cells, so therefore it blocks B cells giving the message. TNF alpha is another cytokine that is inflammatory, and golimumab blocks TNF alpha and was very effective in keeping cells around for longer. And then verapamil is an oral medication that is a blood pressure medication that actually was recently shown to improve beta cell function directly and may have a couple other effects on the immune system. So I think what this shows us is we actually have a lot of promising therapies. And if we can move these back into earlier stages of type 1 diabetes, maybe we can treat with something at stage 2 and stage 3, or do a combination therapy at stage 2 and really get a bigger benefit. When we look at stage 2 of type 1 diabetes, we only have one trial that's been done, and that was with, or that's been effective, and that was with teplizumab through a TrialNet study, the TN10 study, and it blocks T cell activation, and we'll talk more about it again in a little bit here. Okay, so just to review again, we have a patient that screens positive for 2 or more antibodies. They have options. They can do metabolic monitoring every 3 to 12 months, depending on if they're in stage 1 or stage 2, and depending on how old they are, so that we can make sure that they are not going to show up with diabetic ketoacidosis and be really sick at diagnosis, and protect, therefore, their long-term health, both maybe their brain and their metabolic health. And also, if you do that at the beginning and you're not in DKA, there's evidence to show you have improved glycemic control and a decreased risk for complications. So it's very important. The other option is to participate in clinical research studies with the goal of preventing or delaying type 1 diabetes. At the current time, the only study available in stage 2 is anti-thymocyte globulin, or ATG, which is a medication that's given in transplants. And it is available in patients 12 and older through TrialNet. And then there's treatment with the clinically approved teplizumab medication to delay the onset of type 1 diabetes. So if the 2 therapeutic options are in clinic with teplizumab or Tzield, and in research with the TN28 study, I wanted to just review how they act. So we'll start with, on the right, the ATG, which depletes T cells. So by getting rid of T cells, you basically get rid of all the ability for co-stimulation to happen and all of the ability for other cells to give a message to the T cell, because the T cell's not there. And so studies to date have showed preserved C-peptide by doing those mixed meal tolerance tests, and also reduced hemoglobin A1C levels in patients who had stage 3 type 1 diabetes. So again, this is now being moved to stage 2. And then when we look at teplizumab, it is a anti-CD3 monoclonal antibody, and we'll talk more about that. But basically what it does is it causes your body not to be able to give the message to the T cell, so that the T cell can't get activated and instead is exhausted. And so studies in new onset patients have showed, again, improved C-peptide responses, decreased insulin needs, and better A1Cs. And then in stage 2, it showed a delay in type 1 development, which we'll talk more about. So another way of jumping in here to the T cell receptor. So all T cells, T helpers, cytotoxics, which are the ones that directly kill, or the good guys, the regulators, they all have T cell receptors on them. And what a T cell receptor looks like is the T cell receptor itself, where it recognizes antigens, is where the protein fits in from viruses, bacteria, or beta cells. And then on the side, there's 2 CD3 molecules. So what this teplizumab or Tzield drug does is it's an anti-CD3 monoclonal antibody. So it comes and it binds the little pink epsilon chain on the CD3 and inhibits the T cell from really getting the message and being activated. And over time, these 2 guys who have contributed amazingly to this field, Jeff Bluestone and Kevin Harold, have modified this OKT3 or Tzield to make it less, to make your immune system tolerate it better. So before, people got more flu-like symptoms in the first studies 20 years ago when they got this medication, and now it's tolerated a lot better. So this is just to show how many clinical trials it took for this drug to be approved. We're focusing on this study that was done from 2010 to 2019, because that is the TN10 study that led to the FDA approval of teplizumab. But you can just see how many different studies it required nationally and internationally to be able to get to that point. There's ongoing studies now with this drug. PROTECT just finished last year and was positive. The TN10 extension is following patients who received teplizumab in PROTECT. And then there's also a study that was required post FDA approval for kids 8 and younger, since it's only approved for 8 and older, to see if it's safe and effective in that age group. Okay, so the teplizumab trial that led to approval was a placebo-controlled study, meaning that some people get the active drug, some people get pretend drug, because that's the only way you know if a drug is truly effective. And that's actually one of the limitations, or one of the problems we're having with research right now, is that for ATG, for example, it's a placebo-controlled study. So if a person has a choice between research, which we want people to do research to keep advancing therapies and hopefully actually prevent type 1 diabetes, they may not want to do that because they have the chance of getting a non-active medication, where if they do the clinically available option teplizumab, they know they'll get the actual medication. So that's one of the things we're kind of facing as a field right now. But this study tested a single 14-day course of teplizumab to see if it would delay or prevent the clinical diagnosis of type 1. People were TrialNet participants, so at that time, they were only relatives of people with type 1. Since then, it has opened up to anybody who is antibody positive, age 8 or older, and had 2 or more antibodies with an impaired glucose on an oral glucose tolerance test. So the values that Kim showed you earlier are very similar to these, but they're a little different, mostly the fasting plasma glucose. So the American Diabetes Association has changed the fasting plasma glucose from 100 to 126, or 100 to 126. And so there's that 10-point difference that can sometimes lead to a little bit of confusion if patients fall into that 10-point range with the fasting glucose. 112 patients were screened for eligibility, and 76 of them were randomized. 44 received the actual drug, 32 received the placebo medication, and then 44, they were all really included in the analysis. So this is the main take-home message from the study. If you look at the red line, these are the people that received the drug, and it's showing how, as the graph goes down, it's people being lost out of the healthy population because they're developing type 1 diabetes. So if you look at the end of the study here, you can see that about 50% of people at the end of this study who received the drug still weren't taking insulin. And if you look at the gray study, the gray line, sorry, it's the placebo group that did not get the drug. And you can see that by the end of this study, almost 80% of them were taking insulin. So quite a big difference in your chance of taking an insulin if you received the drug. The median time to diagnosis was about 60 months with Tzield and a little over 2 years with the placebo group. So when the data has been followed out further, it's somewhere between 2 to 3 years delay in onset of type 1 diabetes. But what that really means is that some people don't really have much of an effect. And then there's some people that actually have a really great effect, like 7, 8, 9 years, and they all kind of get lumped together, and this is the average. So we don't know really how to pick out the people who will respond really well and the people who will just have a very small response. And that's something hopefully we'll learn over time. If a patient gets this, the most common adverse events they have are that those lymphocytes, those T cells, those soldier cells, because of what's happening to them, which is the antibody binds, it goes inside the little T cell goes out of the blood into the lymph nodes, and then comes back in, and it doesn't look activated anymore, it looks exhausted. So for a small period of time, while those cells go out of the blood, your blood cell count is going to be lower. But by day 6, 7, 8 of the infusion, they're already starting to come back into circulation. And usually by day 14 of the infusion, then they're back to normal levels. Other side effects are rash, headache, and some nausea. This is what the rash looks like. So it's just kind of a red rash, sandpapery rash that is itchy. And so topical hydrocortisone or sometimes Claritin, in addition to the Benadryl they're already getting, helps manage those symptoms. And then the rash goes away after the infusion is finished. So this is just the notice that this drug was approved in November 2022. So it's only been just over a year that it's been approved. And I'm not going to really go over this, but this is just to show that the prescribing information for how to give the drug is extremely limited. And so it's been really hard for a lot of clinics throughout the United States, especially those without any research experience, to adopt giving this clinically. So at our clinic, we opened an early type 1 diabetes clinic in December of 2022, so right after that drug was approved. And to date, we've had 48 clinical visits for people with multiple antibodies who wanted to be evaluated for treatment options because they had had some evidence of abnormal blood sugars or they just wanted to be evaluated. We've seen 20 children, 6 young adults, and then 11 adults all the way up to age 60. So out of our 48 patients that have completed what we call a staging visit, during a staging visit, we do a hemoglobin A1C, an oral glucose tolerance test, and we place a continuous glucose monitor. We also have them have a health and behavioral assessment with one of our psychologists, receive any education that they need from our educator, and then at the end of the visit, be given all the results so that we can determine next steps. So at the end of that visit, 14 had stage 1 type 1, so really just needed to continue to be monitored because there isn't a therapeutic option or clinical trial at this time for people in stage 1. In stage 3, we had 3, and so we sent them to the clinic to begin insulin and be educated. And then 31 were in stage 2. And of those 31 in stage 2, we had one person who decided they didn't want to pursue any treatment. We have 7 people that progressed to having very high blood sugars and needing insulin before they were approved by insurance. And then we've had 16 that have been approved, or 16 that have been approved for Tzield and 7 that are currently pending approval. Of the 16 approved, we've infused 10 patients, which seems very small, but it's by far the most experience out there at the moment. And then we have 3 that are scheduled, and one of those that was approved that declined treatment. And she declined because her father had type 1 and she really just wanted to move on and take insulin. So for our infusion experience, of the 10 people that we've infused, this was our first participant and his family. This is a publicly available picture. The mean age of people we've infused has been 20 years. The range has been from age 10 to 32. 40% have been under 18, 30% 18 to 26 years, and then 20% adults. We've had a majority of male participants, and then 80% have been white with a very low number of Hispanic and Asian, which is not reflective of our new onset population. So we realize that it's harder to identify sometimes racial and ethnic minorities, and we're all as a center working on ways to do a better job with that. So some of the things to think about, if people are wanting to be treated, they have to be identified. And Kim talked a lot about this, but I just want to show how much things have changed. So in 2014, there were the very first recommendations about screening from the American Diabetes Association. And it said, inform relatives of patients with type 1 diabetes of the opportunity to be tested, but only in the setting of a clinical research study. And it stayed that way until 2022. And then in 2022, the ADA said, well, you should get these antibodies, and it's recommended to be screened if you have a family member through a research study, or for anybody else, it can be considered. And then in 2024, it doesn't talk about first degree relatives anymore, and it doesn't talk about research studies anymore. It talks about screening with the 4 antibodies that we talk about. So we've really moved into a phase where screening is trying to move from research to clinical care. And a lot of that is driven by the fact that there's now a treatment option available. So talked a little bit earlier, but these are all of the screening programs everywhere. So there was a question about that. And again, Frida being the one that's the biggest right now, but there are more popping up throughout the whole entire world. There's a campaign that came out from the company that makes the medication called Screen for Type 1. And part of the reason we want to educate, everybody we can, including your group, is because although the campaign is great for increasing awareness, it says, if you want to screen, click here, and then people click here and they can pledge to screen. And then it says, go talk to your doctor. And a lot of times they go talk to a doctor and a doctor says, well, you don't need to be screened. Or, they may talk to any healthcare provider really that they come in contact with, and people will say, well, that's just a marketing campaign. The company wants to sell their drug, which is true, but there's more to it than that. And so If a patient commits to be screened, we want people to have the knowledge so that they actually can get screened if they want to get screened, instead of having nowhere to go and not knowing what to do. So Kim talked about all the different antibodies. So I'm actually going to go through this slide and not focus on it. This is just a graph though showing why confirmation is so important. So when we get antibodies tested from outside the Barbara Davis Center, and patients come to us with antibodies through the Ask the Experts program, if they screened negative through an outside program, they pretty much always screen negative with us too. So outside labs are really good at detecting you if you're not at risk. Where we're seeing a little bit more inconsistency is for patients that screen positive at outside labs. So for patients that screen positive at an outside lab, only 3 of them confirm positive for single antibody at our lab. And so you can see there's a really big, potentially false positive amount from some outside labs. And then if people screen multiple at outside labs, we're seeing that only about half of them confirm multiple at our labs. So this just goes to show that confirmation is important. Screening, we always say, get screened wherever you can. But if you're going to confirm, really try to do it at a lab that is one that's used to doing this. So in the patients that we've seen in our clinic, and this is just for you to kind of understand that out of the 36 patients we've seen, if you look at just A1C, you're going to see that 18 of those patients by A1C were stage 2, so an A1C of 5.7 to 6.4. But if you look at fasting glucose, 16 were on stage 2, so between 100 and 125. And if you look at the 2-hour oral glucose tolerance test value, only 9 were in stage 2. So you really, patients that are who are antibody positive and being what we call staged to see where they're at in regard to their beta cells working, really need to have everything checked, because only 2 patients out of all of these patients showed the same stage for all 3 things, for A1C, stage 2, for A1C, fasting glucose, and 2-hour oral glucose tolerance test. The rest had at least one value that was not putting them in the same stage. And that's because we typically expect that the first thing people are going to have trouble with when they're developing type 1 is responding to a food load. So responding to that sugar load with an oral glucose tolerance test, for example. So they're going to end up first in the red by a 2-hour oral glucose tolerance test. And the very last thing that usually shows up abnormal is an A1C. So it's just something to keep in mind. And this also just shows that there's continuous glucose monitors are great, but there's a lot of variability within stages too. So once you get to stage 3 and need insulin, you're going to have high blood sugars. But when you're in the early stages, some people barely have any abnormal blood sugars, and other people have a lot if they're wearing a continuous glucose monitor. So patients with stage 2, again, it varies by which method you use to categorize them. And as I talked about earlier, that fasting glucose is different between the TN10 study that led to TZIELD approval and the ADA staging criteria. So that's what we have to think about when we're deciding about treatment options. Dysglycemia for approval of this medication varies among insurance payers. So some will say we absolutely have to have an oral glucose tolerance test. There's one insurance company that says they have to have 2. And then there's other insurance companies that say an A1C alone is fine. And then oral glucose tolerance tests are not routinely done in many practices, especially pediatric practices. So this can be really hard for some providers out in the community. And then stage 2 type 1 diabetes for our healthcare system, our medical records, there's not a code for that yet. And so that's also difficult just for purposes of classifying patients. Okay, so how is teplizumab given? So it can be given through an IV or a PICC line. A PICC line or midline are preferred just because they stay in longer, and but it does require scheduling flexibility for that, which can be hard. And then again, if any problems happen with the PICC line, or if there's a fever, then it becomes a little bit more of an issue. So one of the things that happens with teplizumab is that patients can get a fever because that's one of the side effects. But also if a patient has a central line in or a PICC line in, then you worry about infection. So you have to really have someone evaluating the patient each day who is familiar with differentiating between an infection that needs further workup and blood cultures, for example, or just it being a routine side effect of the medication. But because the medication is given 14 days in a row for 30 minutes each day with an hour observation, that can be really hard to do. Infusion centers usually aren't open on the weekends. If you try to do weekends in an outpatient hospital bed, that's really hard to do during viral season like we're all having right now because there aren't beds available. And home infusions, we really don't feel comfortable with because patients have side effects that can be pretty significant. And this drug, we don't have a lot of clinical experience with it, so we really want to make sure patients are safe. So shifting from research to clinical care. So when there's a research study, there's always something called a schedule of events that looks like this, that says like, when do you do a physical exam? When do you do different laboratory tests? So when we're talking about clinical care, we can get rid of a lot of these things that are done during research studies because we're not having to show trying to figure out what the safety problems are with the drug. That's already been figured out. We're not trying to do any extra research to figure out who's responding and not responding, if we're giving it clinically anyway. And so what we've done is we've really limited things. So on the before the first day, you still want to do all of the labs to make sure they don't have an active viral infection and that their blood count and their liver enzymes are normal to start with and that they're not pregnant. And then after that, we just have a few days instead of all these days where we do labs to make sure that their liver enzymes stay normal and their blood count recovers. We know it's going to go down. We just want to see that it comes back up. And we really feel like the patient needs to be evaluated each day just because there are side effects and we want to make sure patients stay safe and healthy until we have lots and lots of experience under our belt and can better decide which days maybe they don't need to be seen. So in summary, establishing a process for screening in high-risk individuals needs to be implemented, and it may look different for each clinical team. Full metabolic testing is important to identify those who might be eligible for treatment, given that some people just will qualify by A1C and some by oral glucose tolerance test. Successful administration requires that the ordering provider and team are comfortable with management of infusion-related issues. And I should mention that these kids typically, because of the side effect of their infection fighting cells being low during the infusion, most of the kids that we see are doing remote school during that time. And we've had teachers all work with them to do that, but they're usually out of school for those 2 weeks. And then by the time they come back, usually their blood cell count is high enough to be fine. If they, for some reason, had a prolonged recovery in their blood cell count, then they would need to mask and take infection precautions until it recovered. And then laboratory evaluation should again be focused on keeping a patient safe. And then participation in registries will be important for understanding the real world impact of this treatment. And this is just our local team, the prevention team that helped lead to the improvement of this therapy locally. And then also all of our nurses that help with these infusions that we're doing at the Barbara Davis Center. And I think it's just exciting that intervening in autoimmune disease is open, but we're going to have a new population of kids that we have to care for a little bit differently than we have in the past.
So Kimber, it looks like there's 2 questions. The first one, it says, are insurance companies covering these screenings and medications?
Yeah, so so how we're seeing the antibodies be covered is like any other routine laboratory test. So most insurance companies cover the laboratory testing. Sometimes there's, a 20% copay up to a certain deductible for laboratory testing, for example. So it really depends on their insurance plan, but they're covered just like any other laboratory test that a doctor would order. I think that there's still a lot of free research programs, but that will eventually go away because everything is available clinically. And the medication, so, I have not had a medication denied that we haven't been able to fight through and get approved yet, other than I would say our government insurance plan. I wasn't able to fight through all the way because the patient was diagnosed before we got approval. And so the other patients that were denied before, like I was working on approval while they progressed, since then, all of their insurance payers we've had other patients infused with. So Kaiser, for example, there were a couple patients that the process was really slow and they needed insulin before they got treatment, but now we have several Kaiser patients. So the medication is super expensive, but insurance is covering it completely if they approve it. And again, we're having most people approve the medication. The company also has a patient assistance program. So I don't know exactly how it has actually played out. I haven't heard any negative feedback from families. How it's supposed to work is that for any co-pays that the family has to make for like the physician visit each day, as an example, or maybe a PICC line placement, anything related to the actual infusion, the company has a reimbursement program where they reimburse the family for that. So I haven't heard anybody say that hasn't happened, but I haven't heard anybody say that is happening either, but that's what's supposed to happen. So I think from a financial perspective, even though the medication is ridiculously expensive, it's actually fairly, accessible with the normal prior authorizations and appeals and fighting for coverage a little bit.
I don't know if they were they getting at the screenings, like the antibody screening too, for this question, you think? But
yeah, I talked about that at the beginning, right?
Okay. So you got that too.
Yeah.
I'm just realizing, I guess when you're answering this live, I need to click on this answer live and then it's going to record your answer. So I missed recording that one. Sorry. So the next one is, I may have missed this. How long are the stages on average? I'm sure it's variable.
Yeah, it's really variable. It depends on, well, some of the factors that influence it, again, are age and the different antibodies that a person has. Once you are in stage 2, 50% of people progress within 2 years. That's been pretty consistent. So stage 1 is typically a lot longer than stage 2 is in general.
And then just some comments about excellent presentation. Thank you. Great information. And then this person, does your website have advice for providers on how to avoid the misdiagnosis of type 2?
I think our website doesn't necessarily directly address that, although we have that type 1 versus type 2 handout, and then a lot of information about, why you should screen for type 1. So, and certainly when we have people reach out to our program, that's a lot of what Kim spends her time and our team spends their time doing, is helping with that, helping patients. And then our goal is to really connect with their PCP or their healthcare provider to try to explain that.
And then the next question is, what are the roles for a pharmacist within your team at the early T1D center with the infusions?
Yeah, so most people giving this medication would have a pharmacist. We do not have a pharmacist at the BDC, which, I wish we did. I really think we need one eventually. And so that's something that I'm actually kind of working on for the future. But right now, our nurses actually have been trained by a pharmacist on our campus and do the mixing with verification, a second verification. So a pharmacist would be key to being in charge of the drug mixing and also all of the other pre-medications and things that are needed.
And then just more comments saying great job with the presentation. And then Courtney said, I was that patient, so I'd love a resource if one becomes available to educate providers.
Yeah, so I would love for you to reach out to us, like to shoot one of us an email or both of us an email, or to basically say what you think would have been helpful. How could we have educated them earlier? Because we have a lot of information, but kind of, knowing the story about where the problems were and what you feel like if they had known earlier, maybe you would have been diagnosed earlier. That would be, I think, really helpful for us. The more that we hear stories, the more we're able to figure out how to create resources.
And I think that's it. One person just said, thanks for sharing the knowledge, and she has more knowledge to share with her students and families at her school. So yay, that's great. I was thinking, should we show it all, like the ask site of like how people can sign up for screening? Yeah. So I have that up. So just because we have some extra time. So this is the ASK program that, most of the people who end up getting screened for antibodies through the Barbara Davis Center, they do it through this avenue. And so you can definitely direct people to this website. It's www.askhealth.org. And then people can kind of peruse around the website, learn more about the screening program, but then it's down here. They can click on this online e-consent, or if they're an adult, they just scroll down a little further and there's one for an adult down there. And then that's how they start the process of doing signing up for the screening. And our options for the blood collection include they can, if they're local, they can sign up to come to the Barbara Davis Center for an appointment and we can collect the blood. We also have a relationship with LabCorp, so we can send the person a LabCorp kit and then they just take it into LabCorp and they draw the sample and send it back to us. And then we also have an option of a home screening kit, and it's a capillary sample. So they receive that at home, and then they collect the sample from a finger poke and then mail it back to us. And then anyone who's negative for antibodies, they're going to get a letter in the mail saying that, the antibodies were negative and to get rescreened in the future. If anyone's positive, we're going to call them and talk to them about that result and then next steps, because we're going to want to confirm that initial positive result. And then anyone who contacts us, Kimber kind of alluded to this, through the Ask the Experts program. So somebody who calls us and says, oh, I had a positive antibody result through clinical, so they did it at Quest, Mayo, LabCorp, anything like that, then we recommend that they confirm that result through the Barbara Davis Center lab through the Ask program screening. So.
Yeah, so I think just two more things to add. One is, we're right at this kind of like we said, everything's been commercially available since 2017. So it's not newly available, but there's still kind of a lack of willingness to do commercial screening because people are scared it won't be covered, as an example. So this is available to anyone in the whole United States. And Ask is really good about partnering with healthcare providers too, if they want to be included. So some other research programs kind of take over. Ask can take over, but also can share everything with healthcare providers as long as the patient consents to that. So I think a lot of people really appreciate that.
All right, I think that's it. I think we've covered it all.
Wonderful. Thank you so much for that. Such great information. We certainly don't have resources like this within the state of Delaware, so we very much appreciate you sharing this with us. And that is the benefit of doing virtual, right? We can cross state lines, and we even have attendees that have registered as far as Nevada, Mississippi, DC. So it has expanded, and that's just great for us. We're honored to be able to do this. So if there are no other questions, I know we're ending a little early, but I will give everyone the full 2-hour time frame here. And I will put in the chat the link for the evaluation for tonight. There will be a separate evaluation for tomorrow. You have to fill out both of them to get credit for both evenings. So make sure that you do that. So there's the link. You have until March 1st, but I highly recommend that you just do it now while you can. And we will be back here tomorrow, same time, same place, and we'll hear from Sarah Ogilvie. Did I say that right, Sarah?
You did. You
awesome.
did.
Wonderful.
Sorry,
great.
I just wanted to say too, thank you to everybody who did the assessment for our part, prior to the information session. Anyone that completed that assessment prior to the information session, we're going to also send you a post assessment as well. And that'll come from Sarah again.
Yeah.
So just be aware of that. So thank you for participating in that. We greatly appreciate it.
Now, Kimberly, if they didn't fill out the pre-assessment, can they fill out the post?
So yes, they can
Okay.
actually. Yeah. So it's fine. You can, that's true. You could actually send it to everybody. Once
Okay.
I get that link, you can still send it to everybody. Yeah.
Cool. Wonderful. And yes, so tomorrow night we'll hear from Sarah, as well as Dr. Ha Fan, a pharmacist that we actually found through the ADCES magazine. So we're very appreciative to both of you for joining us tomorrow, and we will see everybody then. Thank you. It looks like we have a few more questions. Everyone's just saying thank you. And they appreciate the Spanish version as well. So that's a great resource to have.
Yeah, thank you for having us.
Wonderful. See everybody tomorrow.
Okay, bye.
Bye-bye.